to 49%.
Good evening, everyone. Thank you, sir. Thank you, Dr. Rajesh, sir, and Dr. Patnaik, sir. And thanks, Sipla, for giving the opportunity. Today, we will be discussing about the mid-range EF. That is, as Dr. Raju, sir, has already discussed about the reduced ejection fraction. So, what is this heart failure with either mildly reduced or mid-range? So, the earlier concept was the definition of heart failure with preserved ejection fraction and a mid-range, that is in between 40 to 49, and a reduced ejection fraction, that is less than 40%. So the previous mid-range EF category includes who have LVEF 40 to 49% with elevated natriuretic peptides. Those are BNP more than 35 or NT-proBNP more than 125 picogram per ml. And at least one of the structural criteria like relevant structural heart disease, either LVH or left atrial enlargement, and the diastolic dysfunction. And heart failure with preserved EF is more than 50%. So identifying this mildly reduced mid-range as a separate group will stimulate research into this underlying characteristics like age, sex, and other pathophysiological things, and it will guide and treatment of this population. So the newer concept is the term is changed into slightly like a mildly reduced rather than the mid-range. So the presence of NT-proBNP levels more than 125 and BNP more than 35 with evidence of structural heart disease will fulfill the diagnosis, and it is ranged between 40 to 49. And still there is a confusion whether it's 40 to 49 or 41 to 49%. So the older trials, which have 2016 guidelines and have mentioned that it is the mildly reduced ejection fraction is 40 to 49%. So the extensive research has been done since 2016 regarding the mid-range, 40 to 49. More like it is more like the reduced ejection fraction and should be termed like mildly reduced. And after the research, the recent heart failure with reduced ejection fraction trials have taken all criteria, especially the paradigm heart failure in which ARNI was studied versus enalapril in heart failure, and the DAPA-HF trial in which they have studied the dapagliflozin with heart failure and reduced ejection fraction, and the EMPA-REG trial in which they studied the renal outcomes with empagliflozin. So in this, they have mentioned that the EF, they considered the reduced ejection fraction as less than or equal to 40%. So the new 2021 definition have taken it mildly reduced EF as 41 to 49% to avoid the confusion. So the renaming this will give us a better definition, and attempts should be made to make a precise EF measurement like below 50 and above 50. So in between 41 to 49% will be considered as a moderate, mildly reduced ejection fraction. So the mildly reduced ejection fraction should be given a benefit of doubt and should be considered treatment with established therapies, especially with the severely reduced EF. And future trials will be enrolling these patients even up to the normal range, as we know. So the this mildly reduced patients, if you see, they are like more similar to the heart failure with reduced ejection fraction, and they are more common in men, younger individuals, and more likely to have coronary artery disease. Almost 50 to 60% of these patients are having ischemic etiology, and they are less likely to have AF and non-cardiac comorbids. And the ambulatory patients have a low mortality comparing with the both reduced ejection fraction group and also the preserved ejection fraction, which I will be showing you in next slides, the graphs in which you will see that the mildly reduced EF patients are more at a safer zone. And these patients include the patients who are whose EF has also improved from less than 40% to more, or has declined from greater than 50%. So if you see the clinical characteristics, as I have told, the ischemic heart disease has the higher percentage, and in the mid range. And coming to the epidemiological basis studies, the incidence is, if you see the cumulative incidence of heart failures, it is less with the mildly reduced EF rather than with the reduced ejection fraction, which is more common with heart failure, and the preserved EF. So these have a better incidence, lower incidence of the heart failure, comparing with the both preserved and reduced ejection fraction patients. So they have studied the demographic features. They have seen the age group. It is in the higher elderly age group, and females are lesser in these people, and the hypertensives are more common. And coronary artery disease is the most common etiology, and lower incidence of AF you can see. Coming to the systematic review and meta-analysis of all this, if you see the mortality, it is low comparing with the both preserved ejection fraction and reduced ejection fraction. And the cardiovascular mortality and heart failure all are reduced with the mild reduced ejection fraction. If you see the recurrent hospitalization, obviously with preserved EF, it is bit less, which is non-significant, whereas the reduced EF are more at the risk of having recurrent hospitalization. Coming to the outcome registry, the GWTG heart failure registry, it has been noted that the that is mildly reduced ejection fraction fares better comparing with the both other scenarios. So who are these patients of heart failure? So this mildly reduced ejection fraction comprises about 10 to 20% of the heart failure population, and they usually mimic the group with reduced ejection fraction with better survival than them. And the persistent heart failure with mildly reduced EF can be seen in some, including heterogeneous cases, such as infiltrative, restrictive, or hypertrophic cardiomyopathies. And the data from the registry showed that the proportion of patients with mildly reduced EF were relatively stable over time, and whereas the proportion of heart failure with preserved ejection fraction increased from 33 to 39%, and that for reduced EF have declined from 52 to 47%. So who are these patients? So if you see elderly age group are the more predominant, and males are more predominant, and low BMI with functional class, good functional class. And if you see the etiology wise, almost 53% etiology is ischemic heart disease, and the incidence of AF is also less. So the mortality, if you see, comparing the 5-year mortality between the reduced and the mildly reduced and the preserved, it is 5-year mortality is bit similar between the all three. And the ESC heart failure long-term registry, all-cause mortality at 1 year was higher in the heart failure with reduced ejection fraction, and then it is intermediate with the mildly reduced. And the non-cardiovascular mortality was higher in patients with mildly reduced in comparison with the reduced ejection fraction. So the other third Swedish heart failure registry, in which all-cause mortality was somewhat higher but non-significant between both the mildly reduced and preserved at 30 days, 1 year, and 3 years. So it was considerably higher in the patients with reduced EF comparing with the preserved. So if you see the predictors between all the three categories, the preserved EF can progress to mildly reduced or reduced EF over time, especially when risk factors of diabetes, ischemic heart disease, higher severity of heart failure and comorbidities are there, and with low adherence to the treatment. Whereas the younger patients, females, lower severity of heart failure with fewer comorbidities and optimized therapies, there is recovery of the LV function, and the patient moves from the category to reduced EF to mildly reduced, and he can go to the category of preserved EF also. So coming to the temporal changes, these changes can occur in between the three categories whenever there is any deterioration or recovery. So in the CHARGE-2 study, after the median follow-up of 3 years, 21% of the mildly reduced patients transits from heart failure to reduced EF and 45% to preserved EF. So the patients with ischemic heart disease were more likely to be experiencing worsening of EF over time. Coming to the advantages of this predictor, as Dr. Raju has already mentioned, it is very easy marker, but powerful with a powerful prognostic value. And most heart failure trials are based on the LVEF, though there is a high intra-observer and inter-observer variability and arbitrary cutoffs with the temporal changes. So, this is a transitional state. So, the EF can recover or deteriorate. So, you should always monitor the patient on follow-up. So, and coming to the phenotypes, if you see the mildly reduced phenotype is more in akin to our reduced EF in both the phenotype and the treatment aspect also. So, the benefit is more with the using the reduced ejection fraction therapy, especially the key drugs like the RAS inhibitors, mineralocorticoid receptor antagonists, ARNI, beta blockers, and SGLT2 inhibitors. And the role of ICD and CRT, this plus minus for mildly reduced. Only with EF less than 40%, there is definitely benefit, as Dr. Raju already discussed. And coming to the phenotypes, the in between the three, the guidelines have already been discussed by my senior colleague previously. So this is just an expansion of the therapy, extending from the reduced EF. So usually the foundation therapy for heart failure are the main important drugs, which are already discussed by Dr. Raju: beta blockers, AC inhibitors, ARBs, ARNIs in the group of RAS inhibitors, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. And the therapeutic targets, especially the neurohormonal activation, and the other target is the cardiac and vascular remodeling. So thereby, these will prevent the future deaths, reduce the hospitalization, and all-cause mortality will be reduced. So these are various trials, which I'll not go in detail. So which have established the molecule in the heart failure treatment. So the patient aspect, the main goal is to prolong the longevity and improve the morbidity, maintain independence, good well-being, and avoid disability. These are the treatment perspective from patient side. And the physician perspective, to reduce the mortality and to control congestion, we add the drugs, loop diuretics for reducing the congestion, and the rest are the foundation therapy for heart failure. And to reduce the mortality in selected patients, CRT, especially QRS more than 150 with the left bundle branch block, and ICD in patients, especially with EF less than 35%. And in MI patients, less than 40 can also be an indication if there is any history of VT. And to reduce the hospitalization for heart failure and mortality in selected patients, there is role of the other secondary drugs like ivabradine and other drugs. So you can see the pyramid curve. So the chronic heart failure with reduced ejection fraction, these all drugs will be used to improve the hemodynamics and reduce the hospitalization. So these are all the recommendations, especially for the mildly reduced ejection fraction. It is almost similar to the group with reduced ejection fraction, except for the limited data. You can see it's all 2B class, but it is almost similar to the treatment of the reduced ejection fraction group. And in patients with this, the percentage drugs used more commonly are the loop diuretics, especially for decongestion purpose, and the ACARBs and beta blockers and MRAs are the more commonly used other drugs. So it is almost similar to the treatment of reduced ejection fraction. And the treatment response especially is very good in the ARNI group comparing with the all other. And we can see the CHARM study in which they have shown that comparing with the regular placebo, the giving RAS inhibitors have proven role. And they have definitely a good benefit, and even the beta blockers are also proven role, especially in reducing the all-cause mortality. And the mineraloreceptor antagonists, especially the TOPAC trial, in which they have studied more than 45% EF patients, it has shown benefit. And it has a greater effect in reducing the hospitalization for heart failure. And the ARNI also, in pooled data, we can see that the benefit is definitely better than the other AC or ARB taken individually. So these patients, the Paragon heart failure trial also they have studied. So until proven otherwise, you can see that women are at a safer side with the mildly reduced EF comparing with the men, and the ARNI, it has significantly reduced the hospitalization for heart failure and improved the physical capacity, especially in both the mildly reduced EF or the patients with preserved EF. So this suggested that ARNI will also reduce the heart failure hospitalizations and improve the symptoms, especially in both mildly reduced and preserved EF patients. So other thing is the FDA's approval, especially for role of this extended indication for ARNI. And still, like regardless of EF, the treatment of risk factors will help in improvement of the clinical condition, especially the hypertension and diabetes. And the volume overload, that is the decongestion reducing, will also help in treatment. Coming to the uncertainties, these are the uncertainties which will be addressed in the future trials also. Especially regarding the EF and the drugs, especially the ARBs, beta blockers, ARNIs. So concluding, the mildly reduced ejection fraction subgroup resembles the transitional range between the heart failure reduced ejection and preserved rather than the unique subtype, but include these patients who have recovered from reduced EF or who have deteriorated from preserved EF. So usually relatively stable LVEF will be around 40 to 50%. Rest of them will be the transitional group. And more importantly, the different LEF trajectories often indicate different prognosis, and a refined classification may be helpful, especially to understand the clinical characteristics. Thank you.
Thank you, Dr. Naveen. A wonderful presentation. We'll take questions at the end of the, all the talks. Now I request Dr. Jagdish to start off his presentation on heart failure with preserved ejection fraction.
Yeah, 1 second, sir.
We are running a little short of time. I think maybe a concise presentation will be very good.
Yeah, can you see my slides?
No. You should start.
No, not yet.
Naveen, you should stop sharing your screen. Yeah.
Sir, I stopped already.
Yeah. Okay. Now, Jagdish, you can start sharing your screen.
Yeah, can you see my slides?
No.
Not yet.
You have to share. You press on the share screen one.
Yeah, I'm just
Share
sharing.
button at the bottom, yeah.
Actually, my main computer got stuck. Actually, I'm trying from iPad. Now can you see?
We can see.
Yeah. We are. Yeah, we are seeing.
Yeah, okay, sir. So good evening, everyone. I am going to discuss about heart failure with preserved ejection fraction, mainly focusing on the ESI update of 2021. So just for the comparison's sake, the incidence of the heart failure with preserved ejection fraction is almost same as that of the heart failure with the reduced ejection fraction. Almost, if you see this slide, and so the incidence is about 46% with preserved ejection fraction and 46% with reduced ejection fraction, and mid-range being about 80%. And if you look at the 5-year mortality chart, the mortality is almost equal among all the 3 groups of heart failure. So the 5 years in all the 3 groups, the 5-year survival rate is less than 50%. But one of the main disadvantages of this heart failure with preserved ejection fraction is, although most of the existing treatment, they have shown significant improvement in the survival in patients with heart failure with reduced ejection fraction. But most of these drugs are not working in these patients with heart failure with preserved ejection fraction. So because of that, actually the mortality of in heart failure with preserved ejection fraction is nowadays increasing, and the mortality of reduced ejection fraction decreasing. And if you look at the epidemiological studies have shown about 10% mortality, annual mortality, and randomized control trials have shown about 5% mortality. And if you look between heart failure and with preserved ejection fraction and reduced ejection fraction, and most of the deaths are cardiovascular, which is about 50 to 70%, and about 20% from the heart failure and 35% from the sudden cardiac death. And this distribution of modes of cardiovascular death is similar with that of the heart failure with the reduced ejection fraction. But the incidence of non-cardiac deaths is significantly higher for patients with preserved ejection fraction than for patients with reduced ejection fraction, reflecting the higher age and increased comorbidity in patients with heart failure with preserved ejection fraction. And similarly, if you look at the changes in most of the comorbid conditions which are present in heart failure with reduced ejection fraction, they are present in the patients with preserved ejection fraction also, with some differences. I'm just highlighting the important differences. These patients with heart failure with preserved ejection fractions are more older, and they are more likely to be female, and more likely to be a hypertensive population compared to reduced ejection fraction. And although this occurs more common in men and women, equally almost after the 5th and 9th decades of life. And similarly, the most antecedent disease leading to heart failure with the preserved ejection fraction is systolic hypertension, which is present in approximately 85% of the patients. But whereas the ischemic heart disease is the predominant problem in patients with reduced ejection group. So this definition has already been explained by my previous speakers, Dr. Raju and Naveen. And I just want to highlight this topic of preserved ejection fraction. This can be diagnosed by this presence of symptoms and signs of plus or minus signs of heart failure with ejection fraction more than 50. The criteria is there should be some objective evidence of the either echocardiography or by measuring the nitric peptides. So these are the important risk factors which have already been alluded by the previous speakers, and which are mostly shared between all the groups of heart failure. Just before going into the treatment, the guidelines, I just want to mention that, as I said, the diastolic dysfunction is the mandatory criteria for diagnosis of heart failure with preserved ejection fraction. So this can be this diagram shows the diastolic pressure volume relationships. So the diastolic dysfunction can be caused by three mechanisms as depicted here. If you look at the figure 1, which is here, the diastolic dysfunction is caused by abnormal relaxation. So when there is an abnormal relaxation, so there is a slowing of the isovolumic relaxation period and with shortening of the diastosis period. And the second type of diastolic dysfunction is because of the increased chamber stiffness. When there is an increase in the chamber stiffness, the end diastolic pressure volume relationship, the curve is shifted from left to the left and right. And the third one is the pericardial descent. Here, the diastolic pressure volume relationship curve is shifted parallelly upwards. And these three constitute three types of diastolic dysfunctions. And the third one is this curve shows heart failure with reduced ejection fraction, where there is increase in the diastolic pressure, but the curve is shifted to the right. So the important difference between this curve and the rest of the three curves is that, so there is elevation of the diastolic pressure in all the groups, but in patients with reduced ejection fraction, the diastolic pressure is increasing with an increase in the diastolic volume also. But in the presence of diastolic heart failure, the elevation of the diastolic pressure is occurring at the low diastolic volumes or almost at the normal diastolic volumes. So the main pathophysiological mechanism is by increasing the end diastolic pressure in patients with diastolic dysfunction at normal volumes. So this shows, that means this shows when patients with heart failure with preserved ejection fraction, this diastolic pressure volume relationship curve is very steep. That means elevation of the pressures occur even at very low volumes. And when compared to the reduced ejection fraction, the elevation of the pressure, end diastolic pressure occurs with an increase in the volume. And we all of us know that this figure, and which shows that there is an increasing different grades of diastolic function, and there are three grades, as you all know. Grade 1 is impaired relaxation, grade 2 is pseudo-normalization, grade 3 is restricted, which is again divided into type A and B, depending upon the reversibility with drugs or with Valsalva maneuver. And this pressure, LA pressure, LV pressure gradient shows, the graph shows there is a gradual increase in the end diastolic pressure in the left ventricle as well as in the LA as the grade of diastolic dysfunction increases. So the ESC guidelines have proposed these parameters to be measured to detect whether the diastolic dysfunction is present or not. So the first one is the left ventricular mass index. It should be more than 95 grams per meter square in female, or more than 115 grams per meter square, or a relative wall thickness of more than 0.02, or left atrial volume index of more than 34 ml per meter square, or E by E prime ratio at rest of more than 9, or elevated NT-proBNP and BNP levels. And this NT-proBNP level more than 125 in sinus rhythm and more than 365 in atrial fibrillation, or the BNP levels more than 35 in sinus rhythm and more than 105 in atrial fibrillation, and presence of systolic hypertension more than 35 millimeters of mercury, or a TR jet velocity of more than 2.8 millimeters of 2.8 meters per second. And apart from the EF, all these parameters should be looked into when we are doing the echo to diagnose a heart failure with preserved ejection fraction. So this is algorithm. So this has already been alluded by Dr. Razu, how we are going to diagnose all the three types of heart failure with reduced ejection fraction. And ESC has recommended any patient with suspected or symptomatic heart failure, and the first we should do a NT-pro-BNP estimates or BNP estimation. If they are below normal, you can reasonably exclude the heart failure as a cause of symptoms. And if they're elevated, then look for the echocardiography and measure the EF, and then divide them into these three groups. And coming to the management of heart failure with preserved ejection fraction, and most of the drugs are used in the similar to the drugs which are used in the other two forms of heart failure. The nitrates and diuretics are used mainly for the decongestion and symptomatic relief. And the four classes of drugs, RAS inhibitors, MRAs, beta blockers, and SGLT2 inhibitors, they are mainly disease modifying agents and improvement in the mortality in patients with reduced ejection fraction. So this shows the same. The four pillars of heart failure with reduced ejection fraction, these are RAS inhibitors, beta blockers, MRAs, and SGLT2. All these drugs have not, because these have already proven in patients with reduced ejection fraction. Most of the studies now, they are in patients with preserved ejection fraction, they are doing with the same drugs. But mostly the beta blockers and MRAs have not shown any benefit in these patients. Actually, beta blockers sometimes maybe even may cause more harm than benefit in patients with preserved ejection fraction by producing chronotropic incompetence. But two classes of drugs, one is ARNI and the other one is SGLT2 inhibitors. The recent trials are showing some promising in patients with preserved ejection fraction. And I'm just going to show briefly about two trials which led to FDA approval of ARNI in patients with preserved ejection fraction, and similarly one major trial which has led to this guideline-directed indications in the guidelines for SGLT2 therapy in patients with preserved ejection fraction. Of course, RNA, we know that it has a dual beneficial effects of RAS inhibition as well as the stimulation of natriuretic peptide system. And this is a Paramount trial. This is a trial, it's a phase 2 double-blind trial comparing the valsartan with that of the RNA. They have studied only, not the mortality studies, they have studied about the NT-proBNP levels in both the groups. So the group who are receiving RNA have shown a significant decrease in the NT-proBNP levels at follow-up. And coming to the Paragon trial, this is a very large randomized trial done in about 4,822 patients. Here they have compared the patients who are on RNA, about 200 mg twice daily versus 160 mg twice daily of valsartan. And they have studied the primary outcomes and the secondary outcomes. The primary outcomes are mainly the cardiovascular deaths, hospital failure, hospital admission, heart failure hospitalizations, and the combination of the two. So the lower graph shows that there is no significant difference in the cardiovascular mortality between the valsartan group and the sacubitril valsartan group. But there is a significant difference in the heart failure hospitalization between the two. And when there is combined also, there is a significant difference has been shown. So this composite endpoints improvement has been mainly led by the improvement in the heart failure hospitalization rather than increase in the cardiovascular deaths, improvement in the cardiovascular deaths. This has been shown in all the different group of patients they have studied in about 12 groups of patients. And when they looked at the side effect profile, and hypotension and angioedema were more common in the sacubitril valsartan group. But worsening of the creatinine and elevated potassium are seen more commonly in the patients who are receiving valsartan. So, depending on this trial, FDA has recently approved RNA in patients with heart failure with preserved ejection fraction. So this RNA has been already been as a class 1 indication in patients with the reduced ejection fraction to improve the mortality. But in patients with preserved ejection fraction, the indication is mainly to decrease the total heart failure hospitalizations and urgent heart failure visits, not for the increase in the improvement in the mortality. And coming to this SGLT2 inhibitors, this is a very large trial, Pioneer Emperor trial, comparing empagliflozin with the placebo. This trial also has shown significant improvement in the composite endpoints of cardiovascular mortality and heart failure hospitalization. When they compared the heart failure hospitalization, the difference was more. Again, indicating the significant benefit is mainly in the heart failure hospitalizations, not in the cardiovascular mortality. So coming to the recommendations of the latest recommendations of the ESC for heart failure with preserved ejection fraction. So this recommendation is for the treatment of the heart failure in patients with the preserved ejection fraction. So the class 1 indication is screening for and the treatment of etiologies and cardiovascular, non-cardiovascular comorbidities is recommended. And the diuretics are class 1 therapy for decongestion and for alleviation of the symptoms. And for prevention of the hospital admissions and to decrease the long-term hospital risk of these patients, the other recommendations are adequate treatment of the hypertension, and another treatment is the treatment of other comorbid risk factors, and this SGLT2 inhibitor like canagliflozin, dapagliflozin, or empagliflozin has been indicated as a class 1 indication. But in European guidelines, they have not included the ARNI as a therapy for the heart failure with the preserved ejection fraction. And other things are like counseling against the sedentary habits, obesity, cigarette smoking, and other risk factors. So this heart failure with the mid-range ejection fraction has been already covered by Dr. Naveen. So to conclude, and the important take-home message is, heart failure with the preserved ejection fraction is as common, at least as common as a heart failure with the reduced ejection fraction. And echocardiographic evaluation of diastolic function and testing the nitric peptide levels is important in patients suspected of heart failure with preserved ejection fraction. And the mortality and morbidity are also as bad as heart failure with reduced ejection fraction. And the present modalities of the treatment are not as effective as in heart failure with reduced ejection fraction in reducing the cardiovascular mortality. And most of them are useful for symptomatic relief and to reduce the heart failure hospitalization. And the less effective therapy and more lack of effective therapy and more elderly population being affected makes the prognosis of the heart failure with preserved ejection fraction worse than the heart failure with reduced ejection fraction. So the only important treatment modalities at present are decongestion with the diuretics and nitrates, and strict control of hypertension, ARNI to reduce and ARNI and SGLT2 inhibitors to reduce the heart failure hospitalizations. Thank you very much.
Yeah, thank you. Thank you, Dr. Jagdish, for a nice presentation. Now I invite Dr. Patnaik to summarize the treatment algorithms for these different subgroups of heart failure and the role of ARNI in the management of these three groups of heart failure.
Thank you. Jagdish, can you share your...
Yeah, Jagdish, you should stop sharing your screen so that I can share it.
Yeah.
Is the screen visible, sir?
Yes.
Good evening. I would like to make it short because of one